Hello, all of you. Welcome back to my channel. So, today we are learning about a topic related to the diabetic ketoacidosis. Last time I made a video related to the diabetes mellitus. I'm sure you already watched it. If you didn't watch it yet, please go and watch it. You will get a definite, very simplified knowledge related to that. So, let's begin with our today video. That is a very important topic, and on that you definitely get in questions also. So let's begin with our video. So first I will tell you what is diabetic ketoacidosis. Okay, so diabetic ketoacidosis may be a complication that is existing type 1 diabetes mellitus or the first presentation, accounting for around 6% of cases, rarely under condition of extreme stress. Patients with type 2 mellitus may also develop what? Diabetic ketoacidosis, right? So what happened in that diabetic ketoacidosis? What I really want to tell you, this is a complication of type 1 diabetes mellitus. Okay, and that can be happen if there will be extreme stress. Also, a patient of type 2 diabetes mellitus can also develop diabetic ketoacidosis, but mostly this is a condition for the type 1 diabetes mellitus, right? Now let's come to another point. So, diabetes ketoacidosis remains a serious condition. Mortality rates have decreased from 8% to under 1% in the past 20 years, right? Now we'll be discussing about the pathophysiology. So what is the pathophysiology of this? This is caused by uncontrolled lipolysis, not proteolysis. You have to remind such points, okay? Which results in an excess of free fatty acids that are ultimately converted to ketone bodies. So what happens? That is by uncontrolled lipolysis. Repeat with me, okay? And which results in excess of free fatty acids, and that will be converted to the ketone bodies. The most common precipitating factors of diabetic ketoacidosis are infection. Okay, guys, missed insulin doses and myocardial infarction. You have to remember such points. Okay, you have to remember such points that how this can be precipitated. Okay, now as I already told you in our last video also, but I will be telling you back again the features of diabetic ketoacidosis. So that is an abdominal pain, that is in polyuria, polydipsia, and dehydration. So, guys, polyuria meant to be excessive thirsting, and polydipsia to be excessive urination at the time of night, right? And the dehydration. There is a small respiration, that is also known as deep hyperventilation, acetone smelling breath, teardrops smell. Okay, so these features you guys need to remember. Okay, now let's learn about the diagnostic criteria. American Diabetes Association in 2009 and Joint British Diabetes Societies 2013. So this is like a glucose having a 13.8, the glucose is greater than 13.8 millimole per liter, pH is less than 7.30. Okay, uh, let me highlight this. Serum bicarbonate is less than 18, and iron gap is greater than 10, and ketonemia. Now, related to the British Diabetes Societies, this is glucose related to greater than 11 millimole per liter, or known diabetes mellitus. pH would be less than 7.3, bicarbonate less than 15, and ketones greater than 3 millimole per liter, or urine ketones have a positive test on dipstick. Okay, correct? Now let's come to the management. Guys, this lecture is for everyone. Okay. I am having every information in that. A person who is preparing for Neet PG, a person who is preparing for Mrcp, a person who is preparing for FMGE will definitely get a benefit with this lecture. So please do share it with your other friends also, so they will also get benefited with this lecture. Okay, so now let's talk about the management thing. So what is our source of management for this? That is having a fluid replacement. Most patients with diabetic ketoacidosis are deplete around 5 to 8 liters. Isotonic saline is used initially. Please see an example fluid design below. So just remind that what is the management? Management is fluid replacement. Okay, insulin. An intravenous infusion should be started at zero point 0.1 unit per kg per hour once blood glucose is less than 15 millimole per liter, and infusion of 5% dextrose should be started. Correction of hypokalemia, long-acting insulin should be continued, short-acting insulin should be stopped. Now let me tell you, insulin should be given intravenous infusion that will be started with a zero point 0.1, and once blood glucose comes to less than 15 millimole per liter, then you have to infuse the 5% dextrose, and that should be started. Now hypokalemia correction should be there, long acting insulin should be continued, and short acting insulin should be stopped. Okay. Now this is an JBDS example of fluid replacement regime for patient with a systolic BP on admission 90 mmHg and over. So this is an regime given over there. You can just go through with that. Okay. You can go through with that. Please note that slower infusion may be indicated in young adults aged 18 to 25 years, as they are greater risk of cerebral edema. So you have to remember this, that you have to give slower infusion to the young adults who would be having an age 18 to 25 years. Okay, right? As they are greater risk of cerebral edema. Correct? I'm sure you are getting everything whatever I'm telling you, and whatever these guidelines given you have to go through. Okay, potassium level in first 24 hours and potassium replacement in millimole of infusion solution you have to see over 5.5 nil, 3.5 to 5.540, below 3.5 senior review as additional potassium needs to be given. Okay, now complication of diabetic ketoacidosis and its treatment: gastric stasis, thromboembolism. So these are all complications. You have to remember that: gastric stasis, thromboembolism, arrhythmia secondary to hyperkalemia, iatrogenic hypokalemia, iatrogenic due to incorrect fluid therapy, right? Due to incorrect fluid therapy. And there is an cerebral edema, hypokalemia, hypoglycemia that could happen if there will be incorrect fluid therapy, which I already told you. To the young adults, you have to give the slower infusion just because they have a higher risk of cerebral edema. I told you before, please be focused, okay? Acute respiratory distress syndrome, acute kidney injury. Now, cerebral edema is an important complication of fluid resuscitation in diabetic ketoacidosis, especially in young patients. Right? These things are coming back again because these can be framed as a question too. So you have to remind it. Certainly, you have to go through the topic deep down also, and you have to go overview the topic, that whatever things are repeated, you have to remind it back again. Okay. Now, children or young adults are particularly vulnerable to cerebral edema. Following fluid resuscitation in DKA are often need 1:1 nursing to monitor neuro observation, headache, irritability, visual disturbance, focal neurology, etc. It usually occurs 4 to 12 hours following commencement of treatment, but can present at any time. If there any suspicion of a CT head and senior review should be sought. So everything is clear in this paragraph, right? Now let's come to the alcoholic ketoacidosis. Alcoholic ketoacidosis. In this, what is there? That is, alcoholic ketoacidosis is a non-diabetic euglycemic form of ketoacidosis. It occurs in people who regularly drink large amounts of alcohol. Okay. Often alcoholics will not eat regularly and may vomit food that they do eat, leading to episodes of starvation. Right? Now, once the person becomes malnourished after an alcohol binge, the body can start to break down body fat, producing ketones Hence, the patient develops a ketoacidosis. It typically presents with a pattern of metabolic acidosis, elevated anion gap, elevated serum ketone levels, normal or low glucose concentration. Right? Now, let me tell you what I am want to know you from this topic. So, this happens with the non-diabetic euglycemic form of euglycemic form of ketoacidosis. Correct? I hope you know this. Now, who regularly drink large amounts of what happen in this large amounts of alcohol is taken, right? Now, what happen? Alcoholics will not eat regularly and may vomit food. So that can lead to what? Starvation. What happen? They don't eat regularly. Now they vomit food also whatever they have eaten due to having a large amount of alcohol. Now what happened? This leads to starvation, guys. Okay. Now once the person who is now starving because of vomiting now becomes malnourished. Okay. And after an alcohol binge, the body can start to break down what? Body fat. Now person already vomited, they are binge drinking. Now body fat is breaking down. What happened? That produce ketones. Okay, and now patient going to develop ketoacidosis. They can typically present with this symptom pattern also. That is a metabolic acidosis, elevated anion gap, elevated serum ketone levels, and normal or low glucose concentration. Now the most appropriate treatment for this is an infusion of saline and thiamine. Correct? Now this is the treatment for alcoholic ketoacidosis. Now thiamine is required to avoid Wernicke encephalopathy or Korsakoff psychosis. Now this you know. This occurs in who is having the who is drinking more alcohol and everything. This Wernicke encephalopathy or Korsakoff psychosis occurs in those people. So that's why thiamine is given because they will be having a deficiency of this thing. Correct? Now everything is reconnected with each other. If you go with the lecture very deep down and you just make your overview with that, you will definitely get an interconnection. Okay. Now we'll be discussing about the HHS, hyperosmolar hyperglycemic state. Hyperosmolar hyperglycemic state HHS is confirmed by dehydration, osmolality greater than 320 milliosmol per kg, hyperglycemia greater than 30 millimole with pH greater than 7.3, bicarbonate greater than 15 millimole, and no significant ketonemia less than 3 millimole per liter. See guys, I can leave out this thing to read out from you myself, but what I really want now that I will be reading with you, so you will definitely go with each and every points with me together in this lecture, so you don't need to come back and read out from yourself. That's why I'm reading it also. Okay. So hyperosmolar hyperglycemic state. First remind this HHS. Hyperosmolar hyperglycemic state is a medical emergency which is extremely difficult to manage and has a significant associated mortality. Hyperglycemia results in osmotic diuresis. See, osmotic diuresis, now severe dehydration and electrolyte deficiency. What I get for you? This thing, osmotic diuresis, severe dehydration and electrolyte deficiency. Now what happened? HHS typically presents in the elderly with type 2 diabetes. Remind these things, okay? In which that can occur? Type 2 diabetes mellitus and elderly people. However, the incidence in younger adults is increasing. Now it's increasing, but mostly it is occur in elderly type 2 diabetes mellitus people. It can be initial presentation of T2D. So let me write the main thing over there. T2, DM and in elderly. But now the cases are increasing in younger adults too. Okay, it is extremely important to differentiate HHS from diabetic ketoacidosis. Now let's see what is the differentiation they want to tell us. It is extremely important to differentiate HHS from diabetic ketoacidosis as the management is different. management is different, and treatment of HHS with insulin can result in adverse outcomes. Okay, as part of a DKA protocol. The first 24 hours of treatment is very labor intensive, so these patients are best managed in either a medical high dependency unit. Okay, so these patients for the first 24 hours need a very intensive care, so they are treated in medical high dependency unit. Okay, HHS has a higher mortality than DKA, so this is higher mortal than the DKA. You have to remind such things. This is a higher mortality than DKA and may be complicated by vascular complications such as myocardial infarction, stroke, or peripheral arterial thrombosis. So, by this, you can just definitely get to know that this is more mortal because that can have a complication, myocardial infarction, stroke, and peripheral arterial thrombosis. Seizures, cerebral edema, central pontine myelinosis are uncommon but documented complications of HHS. So, these are documented. These are uncommon but documented. Okay. While if we talk about the DKA presents within hours of onset. HHS comes on over many days, and consequently, the dehydration and metabolic disturbances are more extreme. Now, let's come to the pathophysiology of this. Hyperglycemia results in osmotic diuresis, I already told you, which is associated with low of sodium and potassium. Here occurs what thing? Low of sodium and potassium, correct? And there will be an osmotic diuresis. Severe volume depletion results in significant raised serum osmolarity, typically greater than 320 milliosmol per kg, resulting in hyperviscosity of blood. Now, what happened there? Hyperviscosity of blood. Remind these things, osmotic diuresis is there, hyperviscosity of blood is there. Okay, despite these severe electrolyte losses and total volume depletion, the typical patient with HHS may not look as dehydrated as they are because hypertonicity leads to preservation of intravascular volume. Okay, so what happened in that? In DK, there is an consequently high dehydration and metabolic disturbance there, but in this, the people are not look as much as dehydrated. Okay, now let's talk about the clinical features, which will definitely gives you a certain points to remind every information, right? Now, clinical features: general fatigue, tiredness, lethargy, nausea, and vomiting. Correct? Let me remove this. Yeah. Okay. Neurological, altered level of consciousness, headaches, papilledema, weakness. Correct. Hematological, hyperviscosity may result in myocardial infarction, stroke, and peripheral arterial thrombosis. Cardiovascular, there will be a dehydration, hypotension, tachycardia. So these are the clinical features which you people going to remind. So you will get to learn a lot of things, right? Now with the diagnosis part, let's discuss hypovolemia, marked hyperglycemia that would be greater than 30 millimole per liter without significant ketonemia or acidosis. Now raised serum osmolarity greater than 320 milliosmol per kg. Note, a precise definition of HHS does not exist. There is not exact information given for the HHS. However, above three criteria are helpful in distinguishing between HHS and DK. So, guys, this criteria is not as precise because it's not as precise given over there. But what happened? Like we can make a differentiate between the HHS and DK. It is also important to remember that a mixed HHS or DK picture can occur. It could be possibility that both mixture can be occur. So there are a lot of things you have to get focused, right? Now let's come to the management. The goals of management of HHS can be summarized as follows: normalize the osmolality, What will you do? Normalize it, replace fluid and electrolyte losses. Whatever the losses of electrolytes have occurred, you have to replace those and normalize blood glucose gradually. Fluid replacement 10 to 22, 0.9, and this you have to go through. Fluid losses in HHS are estimated between 100 to 220 milli per kg, and the rate of rehydration will be determined by assessing the combination of initial severity and pre-existing comorbidities. So you have to remind these things. Example: cardiac failure and chronic kidney disease. Caution is needed, particularly in the elderly, where too rapid rehydration may precipitate in heart failure, but insufficient may fail to reverse an acute kidney injury. Now, what happened? You have to rate the determined as rehydration, okay? Because that can be related to having a severity, initial severity also, and comorbidities also. Like if the person who is elderly and who have a too rapid rehydration can precipitate the heart failure, and the insufficient would be fail to chronic kidney, like sorry, not chronic, acute kidney injury. Okay. Now let's come to intravenous. 0.9 sodium chloride solution is the first line. Fluid for restoring total body fluid. It is important to remember that isotonic 0.9% sodium chloride solution is already relatively hypotonic compared to the serum in someone with HHS. Therefore, in most cases, it is very effective to restore normal serum osmolarity. If the serum osmolarity is not declined despite positive valence 0.9%, fluid should be switched to this 0.45% chloride solution, which is more hypotonic related to the HHS patient serum osmolarity. You have to read it, go through with this, okay? IV fluid replacement should aim to achieve a positive balance of 3 to 6 liters by 12 hours, and the remaining replacement of estimated fluid losses within the next 12 hours. So guys, this is very technical medical knowledge, okay? We learn the facts and factuals for the topic, but we never get to learn these things related to the clinical expectance. So you have to learn these things, like how we have to change the our um like these percent of our components, like related to the sodium chloride and everything. We have to learn such things. These are very important things, but we don't used to learn this thing, we don't used to remind this thing. Only when we treat our patient, we just go through with these sort of things, right? So now we have a time to learn these things also. Existing guidelines encourage vigorous initial fluid replacement, and this alone will result in a gradual decline in plasma glucose and serum osmolarity, a rapid decline in potentially harmful. Therefore, insulin should not be used in the first instance unless there is significant ketonemia or acidosis. So what happened? Insulin is not used first in a first instance, because there will be a significant ketonemia and acidosis can be occur. Okay, that's why, right? Now the aim of treatment should be to replace approximately 50% of estimated fluid loss within the first 12 hours, and the remainder should in the following of 12 hours. However, this is just a guide, and clinical judgment should be applied particularly in patients with comorbidities such as heart failure and chronic kidney disease, which may limit the speed of correction. So what happened? This is the guide for the clinical judgment. Like a person who would be having comorbidities related to the chronic kidney failure or the heart failure, that person needs to be focused a lot with this clinical judgment, okay? Because they may limit the speed of correction. Monitoring response to treatment of this, you just go through with that. Rapid changes of serum osmolarity are dangerous. See, a lot of things you get to know. Why? Can result in cardiovascular collapse and central pontine myelinosis. Sometimes what happen na, we don't go through with these clinical judgments thoroughly, and we don't remind it thoroughly, and sometimes case get worse just because of these clinical judgment things also. Yeah. So learn basics, also learn more clinical judgments. Guidelines suggest that serum osmolarity, sodium and glucose levels should be plotted on a graph to permit appreciation of the rate of change. They should be plotted hourly initially. So what happened, we have to plot a graph and we have to maintain this graph hourly, so we can just get to know the rate of changes. Not all laboratories have readily available access to serum osmolarity measurements. If not available, then a calculated osmolarity can be estimated with 2 sodium plus glucose plus urea. Fluid replacement alone without insulin will gradually lower blood glucose, which will reduce osmolarity. A reduction of serum osmolarity will cause a shift of water into the intracellular space. This inevitably results in a rise of serum sodium. A fall in blood glucose of 5.5 millimole will result in a 2.4 millimole rise in sodium. This is not necessarily an indication to give hypotonic solution if the inevitable rise in sodium is much greater than 2.4 for each 5.5 in blood glucose. This would suggest insufficient fluid replacement. Rising sodium is only a concern if the osmolarity is not declining concurrently. Rapid changes must be avoided. A safe rate of plasma glucose of between 4 to 6 millimole per hour is recommended. Rate of fall of plasma sodium should not exceed with this. A target blood glucose of between 10 to 50 millimole is a reasonable goal, and complete normalization of electrolytes and osmolarity may take up to 72 hours. So guys, what I really want to just read it back again after this watching lecture and just write these values on a paper and make a chart, right? Focus on each and everything, make out the take out the points whatever is given and whatever you feel the importance. Okay, so let's come with the insulin. Fluid replacement alone with 0.9% sodium chloride will result in a gradual decline of blood glucose and osmolarity. Okay, what this do, fluid replacement alone what can do? That will gradual decline of blood glucose and osmolarity. Because of most patients with HHS are insulin sensitive. Example, it usually occurs in T2DM. Administration of insulin can result in a rapid decline of serum glucose and thus osmolarity. Insulin treatment is prior to adequate fluid replacement may result in cardiovascular collapse. Okay, see this. As the water moves out of the intravascular space with a resulting decline in intravascular volume. A steep decline in serum osmolarity may also precipitate CPM. Measurement of ketones is essential. Determining if insulin is required. If significant ketonemia is present, 3-beta hydroxybutyrate is more than 1 millimole per liter. This indicates relative hypoinsulinemia and insulin should be started at time 0. Example, mixed DKHHS picture. The recommended insulin dose is a fixed rate of intravenous insulin infusion given at 0.05 units per kg per hour. If significant ketonemia is not present, 3-beta hydroxybutyrate is less than millimole, and then do not start insulin. That's why I was telling that the treatment related to the HHS is kind of different and you have to focus with a lot of things, right? Now, management is literally different and we have to focus a lot on this. Potassium patients with HHS are potassium deplete but less acidotic than those with DK. So, potassium shifts are less pronounced. Hyperkalemia can be present with acute kidney injury. Patients on diuretics may be profoundly hypokalemic. Potassium should be replaced or omitted as required. So guys, I am doing this lecture till here only because if I will be taking this diabetic neuropathy also in this lecture, the lecture will have a increase in size limit and somehow people used to think that we will get any small lecture so we can go through with this as a like a parts in a parts if it's given, you guys like to watch it, so I just want to stop it over here. And in this everything is combined, you just need to go through, you have to listen everything. I read it from my side but you guys also read it from your side and write down on your paper and make notes by yourself. Okay, and I will be definitely taking another lecture with another topic, and I hope you like my video. And also I used to post the shorts for the mnemonics, you just guys go through with that where you can remind things very easily, right? So I'm trying my best, and you just give me one thing, that you just share it with your friends and your colleagues, so I can get more people to see my lectures. And thanks for watching me. Meet you in another lecture. Bye bye. Take care. Have a nice day.